Chapter 19, Respiratory Emergencies. I've mentioned a few times through the course that the number one call for EMS, the number one thing that we are requested for is difficulty breathing, and that obviously is what we're going to cover here in the respiratory emergencies. There are obviously a number of objectives for you for this chapter. A lot of very important information here, things that not only gets used with respiratory problems, but also with several other types of problems that we run into. So we're going to discuss a little bit about ventilation again, the respiratory process again, and then talk about a few of the different types of medical emergencies go along with this and any additional treatments that may go with this. So a couple of multimedia slides, one about chronic obstructive pulmonary diseases. That term itself is a generic category. Spontaneous pneumothorax, which is a rare but interesting phenomenon that occurs, and then the use of a metered dose asthma inhaler and a spacer video. Spacers, when you guys get to that video, spacers are not an incredibly common thing anymore. They kind of come and go, but they're a very effective thing, particularly in EMS when we're trying to treat patients with only the metered dose inhaler as opposed to a nebulizer in which the paramedics would do. So our core concepts: identifying adequate versus inadequate breathing, identifying and treating patients with different breathing difficulties, and the use of a continuous positive airway pressure device to relieve respiratory difficulty. CPAP itself right now is a very hot topic. It is not currently in the scope of practice of an EMT yet in Iowa. It is in Nebraska. Iowa is looking at it, but it's a very beneficial device, and it rolled out to paramedics a number of years ago, and it's just kind of been trickling down ever since. We're also going to talk about use of prescribed inhalers and how to assist a patient with one, and we'll briefly touch on the use of a small volume nebulizer to a patient and assisting them with taking that as well. So we start with respiration. You remember that respiration versus ventilation, the term respiration actually means gas exchange. Ventilation itself refers to the movement of air in and out. Of course, you have to have ventilation in most cases to have respiration. There's a couple of advanced medical procedures that actually can bypass ventilation, but really, if you don't have the air going in and out in one way, shape, or form, you're not going to get respiration. So to look again quickly at this picture, we have the major components, the physiologic components here that make ventilation occur. You have the trachea that branches into the bronchi or the bronchus, mainstem bronchus, and branches down till you get to the alveolus. The point of this picture, though, is really looking more a little bit at the structural components here, being the pleura, visceral and parietal, the thoracic wall, the diaphragm. The thoracic wall, of course, has not only the ribs, but has the intercostal muscles. There's a variety of other accessory muscles that can be found up into your neck and into your back that can assist with respiration as well. Remember the pleura, that's one layer covers the visceral pleura, covers the outside of the lung, and the parietal pleura covers the inside of the chest wall. And it's the purpose of the pleura to cut down on friction and to keep the surface tension so the lungs don't deflate. So inspiration, remember, an active process, uses muscle contraction to increase the size of the chest cavity. So most people, when we take a look down at our chest, we inhale, we see the chest come outward and inward, outward and upward, comes outward and upward as the chest fills with air. The intercostal muscles in the diaphragm contract, that helps pull the lungs up and out and then push down on the abdominal contents, and it creates that negative pressure within the chest wall. So when that diaphragm moves down, the ribs move upward and outward. then we get air pulled into the lungs because it is lower pressure inside the chest than it is outside the chest. So the outside of the chest wins and it pushes some extra air in. Expiration, on the other hand, remember, a passive process. The muscles in the diaphragm relax. Doesn't require any extra energy to do this. It's just a natural process. The size of the chest cavity decreases. Therefore, it increases the pressure within the chest, or the inner thoracic pressure. And with that, because the pressure inside the chest is higher than it is outside the chest, it pushes the air outward, and then air will flow out of the lungs. So signs of adequate breathing, again, breathing that is sufficient to support life. The signs of adequate breathing include people that are not in any obvious respiratory distress. Generally, they can speak in full sentences. They typically have normal color, normal mental status, and are fairly oriented. These alone are not specific things that say inadequate breathing. There's not an end-all, be-all here. It's not a one cardinal sign. So if you would have somebody who has an abnormal color, or maybe they're disoriented, that doesn't necessarily mean they have inadequate breathing. But it certainly may be a sign when you take a look at it in the broad picture. Additionally, the rate of breathing is within the normal limits. And this would be, if you have forgotten this, a good thing to commit to memory again. The normal respiratory rate for an adult is typically 12 to 20, 15 to 30 for a child, 25 to 50 for an infant. Rhythm is usually regular, and the breath sounds are normally present, equal, or sound the same on both sides, and are typically fairly quiet. You don't hear a lot of extra stuff going on. So again, these signs or symptoms themselves are not all-inclusive, meaning, oh, absolutely having difficulty breathing. Somebody has a respiratory rate of 8 or 10 in an adult, and maybe they're very fit, that falls outside of that category. So we have to look at the whole picture. So signs of inadequate breathing typically are the opposites of what we just discussed, but a rate outside the normal range, irregular rhythms, so they're not spaced the same apart each breath, diminished or absent lung sounds, potentially even some other oddball lung sounds. They have poor tidal volume, or the amount of air they're pulling in and out is not sufficient. There's really not a good way to accurately measure that, but the way that we typically will consider that in EMS is, do we see decent chest rise and fall? Signs of inadequate breathing in infants and children. We'll talk about things such as nasal flaring, where they make their nostrils really big. They're trying to make their airways bigger so they can move more air in and out. Grunting. Occasionally we have kids that are grunting when they're trying to breathe, and they're actually trying to splint their own airways open. Seesaw breathing. This is when the abdomen will push outward, the chest will suck inward, and then vice versa. That chest will push outward and the abdomen will suck inward. Whereas in most adults, if we take a big deep breath, we'll see both our chest and our abdomen move outward at the same time, and then when we exhale, they both move inward at the same time. So it's when you see the opposing forces going in a child, is called seesaw breathing. So the abdomen goes one way, the chest goes the other. And then retractions. Now retractions can also occur in adults. They're more commonly seen in kids because kids don't usually have the muscle and fat masses to cover some of these retractions. And in the adult, we typically have a little more tissue, so it's not as obvious. But retractions is when tissue, soft tissue, gets sucked into voids or soft spots in between rigid structures. Some of the most common places to see this, you see retractions up around the clavicles or the collarbones. So that soft tissue, if you basically draw a line straight down the side of your neck, almost where your jugular veins would be, there's a little soft patch in there right behind your collarbone before you get to the big muscle mass in the back. A lot of times that's a place in which you'll see some retractions. You'll also occasionally see retractions between the ribs. So the rib tissue kind of sucks in, and that would be retraction. Then one more big place, and particularly in infants, that you might see is a abdominal retraction, where you actually see it kind of suck up in. It's kind of like seesaw respiration, same sort of concept. Additionally, when we're talking about infants and children's airways, we have a few things that we need to keep in mind. Number one, we have a much smaller airway that's more easily obstructed. There's in infants or in small children, a lot of times paramedics will try to determine what size ET tube or endotracheal tube to put in a kid by comparing it to their little finger. And that's a fairly accurate way to judge how big is that airway. But remember, in an infant, the size of a standard small drinking straw or pen, that's really about the size of an infant's airway, easily obstructed by something as small as just a pea. So in the adult, you're talking an airway that's closer to your probably index finger, if not your thumb, in size. Proportionally larger tongues. Remember, they have the big head, and that big head has big structures, and those big structures maybe don't work as well with their related structures, because the neck isn't big, the head is big. So the things in the neck are small, things in the head are big. So if you have a big tongue, it's easier to block a smaller airway. They have a smaller, softer, more flexible trachea. Something you also need to know about a kid's trachea is it's more funnel-shaped. In an adult, it's pretty much a straight pipe or straw, really. Whereas in a kid, it's kind of a funnel shape. So from the top of it, it starts to get narrower and narrower and narrower until it gets down to the vocal cords, which is where it's at its narrowest. They have less developed, less rigid cricoid cartilage. So all the structures in their neck haven't fully calcified. So it's easier for some of those structures to kind of start to collapse a bit. And so with that lack of cricoid cartilage, which is the only complete ring of cartilage in the neck, it could possibly cause them to have some almost sucking their airway shut. And then they have a heavy dependence on their diaphragm for respiration. Their muscle masses are not fully developed yet. They can't use as much of their accessory muscles to assist them, so the diaphragm really becomes a bigger issue. The other thing is the bones are not calcified in their chest, so the ribs don't do their job quite as well as they do in the adult. So, patient care for our inadequately breathing patient. We've already covered these concepts, but let's recall them once again. Assist the ventilation with supplemental oxygen when possible. Okay, if all we have is a pocket mask or a bag valve mask and we don't have oxygen, it'll do. If we don't have oxygen and we're using a flow-restricted oxygen-powered ventilation device, we're hosed because that is oxygen-powered. If you have no O2, you're out of luck. So then you would have to default to one of your other two devices. When we can use supplemental oxygen, great. If we don't have it, we'll do it with room air until we can get something. So remember, with a pocket face mask, sometimes they may have an oxygen inlet port on them, and that oxygen inlet port you can hook up just a connection tubing that will increase the amount of oxygen that flows into your patient. It can usually be, you usually will run that up to about 10 liters per minute or so to help increase the quality of breaths that you're giving to the patient. If you have a pocket mask that does not have that port, then you can always put yourself on a nasal cannula, crank the nasal cannula up to about 6 liters or so, and therefore what you exhale will be a higher concentration of oxygen because you only use the 5% that you were going to use. So if you cranked it up to 6 liters usually equates to roughly 44% FiO2, or the fraction of inspired O2. So if you take 5% out, you give them 39%, roughly 39% FiO2 when you exhale. As opposed to room air, we get 21% in and we breathe 16% out. So it's quite a nice jump. Looks kind of funny, but it works. 2 rescuer, 1 rescuer BVMs. Remember, usually we like to have oxygen with those when possible, and usually around 10 to 15 liters per minute. 15 is usually where we start. If we are making small enough breaths that we're not collapsing our bag, we might decrease our O2 a little bit. But remember, if we've got the hands, 2 rescuers is the preferred method, because 1 person holds the mask and gets a good mask seal, 1 person squeezes the bag. And then the flow-restricted oxygen-powered ventilation device, often called the demand valve. This device requires you to be very attentive to what's going on with your patient, because if you continue to squeeze or pull or push the trigger, however your device is set up, you will continuously give them oxygen, and 100% oxygen, until you let it go. So you can very easily overinflate people. Artificial ventilation can be adequate or inadequate, and we will assess this basically like we do a patient's normal ventilations. Are we seeing good chest rise and fall? Are we ventilating them in a range that's normal or appropriate for our child? Now typically we'll start somewhere around 12 breaths per minute for an adult, 20 breaths per minute for infants and children, maybe even go a little less on adults, depends on their needs. So roughly once every 5 to 6 seconds is when you're going to be given a breath to an adult, so that would be 12, if not just a hair less, if we go by that standard. So we're going to watch that chest rise and fall. We're going to pay attention to things like their skin color. Do we see the patient start to improve with their mental status? Do we see oxygen saturations changing if we're using a pulse ox? Does the patient have changes in their pulse rate? Does their heart rate, if they previously were very tachycardic or fast, does their heart rate come down closer to a normal range? Or vice versa, if they were very slow, does it come up to a normal range? And that basically just kind of covers increasing pulse rates can indicate inadequate artificial ventilation. So if we're not doing a good job and we see that heart rate continue to drive up, that's something that can help us gauge. Maybe I need to bag a little faster, maybe I need to pump my O2 up a little bit. Decreasing pulse rates can indicate inadequate artificial ventilation in pediatric patients, and the same in adults as well, but that will typically be right before they would arrest. In the kids, you'll see that a little sooner than you do in adults. So how might you recognize the progression from adequate breathing to inadequate breathing in the assessment of your patient? Well, again, you look at all those different things that we've previously touched on the last few slides. Can they talk in normal sentences, or can they only say 2 or 3 words at a time before they have to gasp? Do you hear weird lung sounds or weird audible sounds where you walk in and you can hear them breathing before you even use a stethoscope on them? Is their heart rate way out of whack? Is their pulse ox way off? Is their color bad? Are they sweaty? Are they complaining of things like chest discomfort? So all these things can be signs. How might your patient change during this transition? Well, the number one thing that people have when they are hypoxic, and it's often overlooked, is they become very anxious. So they'll get very anxious, maybe even start to get a little bit on the combative side, and then they'll turn around and they'll start to become very quiet. So to talk about breathing difficulty, here's a good sign that the patient is having some difficulty in breathing. This patient is exhibiting something that we refer to as the tripod position, where he's propping himself up with his arms, leaning forward. That's the easiest position for this chest to expand. So to be in that position, that's kind of a key tell right there, a key sign that, hey, this patient's having a little struggle. So difficulty in breathing or shortness of breath, this is the patient's subjective perception. We cannot say that they are having difficulty breathing. We can say that they appear to be in respiratory distress. We can say that they appear to have very labored breathing, very rapid breathing, it appears that they're having a difficult time catching a good breath, but really the complaint of shortness of breath comes from the patient. Oftentimes it'll be described as that very hard to catch my breath, or it's very difficult to get a good breath in. I feel like I can't catch my wind. The amount of distress felt may or may not reflect the actual severity of the condition. People are all very different. You have, young athletes that maybe have struggled with asthma quite some time, but can really deal with their asthma pretty well, whereas you get maybe somebody who is either a new onset asthmatic or somebody having a severe attack, and it becomes very difficult right away, and they're almost like it's the end of the world. There are some people who tend to get much more short of breath much quicker. Patients that have congestive heart failure, which often exhibit in that tripod position, but patients with congestive heart failure often will go from feeling pretty well fine when they went to bed and waking up in the middle of the night, and it's absolutely terrible, terrible. Can't get a breath. So don't forget our assessment tool of OPQRST, and O, remember, is onset, when did it begin? P, provocation, and remember I also like to throw palliation in there. Provocation, what were you doing when it came on, what makes it worse, and then palliation is what makes it better. Quality, do you have a cough? Do you bring anything up with that? That's called a productive cough, or a cough, I like to call it a cough with a present. And then if you bring anything up with that, what color is it? People who have infections typically will have yellowy, greeny mucus, sometimes some red streaking in there. People with congestive heart failure might have pink, frothy, almost foamy looking stuff they spit up. Might be white, might be slightly pink. You might have people who are coughing up just straight blood. Radiation. Do you have pain or discomfort anywhere else in your body? Now this radiation, when we talk radiation here, it doesn't specifically refer to the shortness of breath or the difficulty of breathing, because you don't get shortness of breath in your toe, but this helps us remember to say, okay, is there any other part of your body that you're having problems with? Does it feel like you have constriction around your chest? Severity, on a scale of 1 to 10, how bad is your breathing? And time, how long have you had this feeling? Now, you can also dabble a little bit more into the history here with asking questions like, have you ever been hospitalized with this before? How often have you been hospitalized with this problem? Have you ever been on a ventilator for this problem? And if they tell you, yes, I've been in the hospital 4 times this last year for this, and I've been on a ventilator 3 of those times, that should be a signal to you that this person can go south very quickly. Time can also be used here to say, to get more question and answer about the history. Maybe we want to know more about specifically what brought this on, which is actually event leading up to from sample. Maybe we want to know, have you recently had a fever? Have you recently been sick? How about a recent trauma or injuries to your chest? All right. So our observation, we're going to look at their altered mental status. Do they have any altered mental status? And remember, altered mental status doesn't mean that they're unconscious or they're completely unaware of what's going on. It simply means that things have changed a bit for them. So they may not be able to, maybe they're very short. They're very short to answer. Maybe they're snappy and crabby. They may have some unusual anatomy, or something called a barrel chest. The barrel chest, if you think about your chest, and without the external lady parts attached there, think about what the actual shape of most people's chest would be. If we cut them in half, right through, basically mid-chest level, we just cut them right in half, top and bottom, what would we see? Well, it would be an elongated oval, basically, in most people's chests. Whereas people with barrel chest, their chest almost has taken a round shape, hence the name barrel. But it's gone from the elongated from shoulder to shoulder to almost rounded, almost perfect circle. The patient's positioning. Do they have any tripod positioning going on? You saw the picture of the tripod positioning. There's another example on 451 in your text. Are they sitting with their feet dangling? Are they leaning forward? Do they have their arms out in front of them? Because that can make it a little easier. Or are they slumped over? They're slumped over in a chair because they don't have the strength to hold themselves up. What sort of work of breathing are we seeing? Do we see any retractions or that soft tissue sucking down in between the hard tissues? Accessory muscle use, muscles in their neck really straining, muscles in their chest and abdomen getting used. Do they have any flared nostrils? Pursed lip. Pursed lip is how you look when you're trying to whistle. Well, oftentimes patients, particularly those sometimes with COPD or congestive heart failure, will breathe pursed lip. So when we say that, they're actually not trying to take a breath in that way. That's the way they're trying to exhale, is they hold their lips close together and kind of will breathe out through their lips and almost get you that whistle sound. But that's their way of keeping their airways open, is they're keeping a little back pressure. It's actually what we often will call auto PEEP, and we're going to talk about PEEP and CPAP eventually here in this chapter, but they're trying to do that for themselves, trying to CPAP themselves really. And then the number of words a patient can say without stopping. Can they say a complete sentence, or do they only get a 2 to 3 word phrase out before they have to take another breath in? They may look pale, they may look cyanotic, they may be flushed, they may be, and then pale, remember, is white, cyanotic blue, flushed is red, or they may also be something called mottled. Mottled is not typical, but it can happen depending on the situation, but mottled is that kind of marbly look to their skin. Do they have any edema? The term edema means fluid buildup or swelling from fluid buildup, and they may have pedal edema, and pedal refers to the foot, and sacral has to do with the sacrum, so that can be the lower back. It's very common for us to see pedal edema, particularly in patients with congestive heart failure, because water is going to go as far down as it can go. Gravity is going to pull it down. People who are bed confined or really just don't get up at all, maybe they spend their entire time with their feet up in a recliner, may have sacral edema, where they get very puffy right down there around the back of their pelvis. And it's not often seen by us because we don't often go looking very closely, but it's there. That's just pooling of fluid in the dependent areas. And are they coughing? What sort of coughing? They have a lot of dry cough, or is it a moist cough? Are they able to actually cough something up? Here's a fairly good picture. This is the one that's on 451 in your text, but it helps us remember some of the signs and potentially symptoms that we're going to have with patients with difficulty breathing or respiratory problems. So altered level of consciousness, which can be anywhere from unconsciousness, dizziness, fainting, restless anxiety, confusion, combativeness, flaring of the nostrils and pursed lips. They may have coughing, crowing, or a high-pitched barking sound. High-pitched barking sound very common with kids. Straining of the neck and the facial muscles. Cyanosis, and this is an African-American gentleman. Cyanosis may not be immediately seen on a person with darker skin tones, but remember, if you look inside the mouth and often at the nail beds, you can start to detect this. They may have complaint of some tightness across their chest. They may have complaint of chest pain itself. Sometimes that's what we actually get called for, is chest pain. Come to find out, it's really more the breathing. When we listen to their lungs, we may hear things like wheezing or snoring or stridor. There's some other sounds. We're going to talk about sounds a little bit later. They may have some straining of the intercostal and abdominal muscles, tripod positioning, may even complain of numbness or tingling in their hands and feet. That's called the carpal pedal spasm, and that's more common in people who are hyperventilating, whether that's for a medical or a psychological reason. That's harder for us to detect in the field, but they'll get that carpal pedal spasm where their fingers and toes get numb, and they may even start to curl up a little bit and spasm. So noisy breathing, what do we hear? Audible wheezing, which is heard without a stethoscope. When we say audible, it's heard without assistance. When we say auscultated, it's with the use of a stethoscope. So audible wheezing, we probably have all heard this. Maybe even when we were kids in school, we heard our friend who had asthma, or maybe ourselves, wheezing a bit. When we were exercising, we were out in the cold, exposed to some irritants and whatnot. You can have non-audible wheezing, in which you have to use your stethoscope to detect. You can have some gurgling. Gurgling typically is only seen in most unconscious or nearly unconscious patients because they are unable to clear their own airway. Snoring. Snoring is fairly common. It's a very common thing that occurs every night in beds across the world, and it occurs for really the same reason. Snoring occurs because of partial airway obstruction from soft tissue. And so that could be the soft tissue as the tongue or parts of the soft palate are relaxed back and partially blocking the airway. So people who snore on a regular basis, they get tired, they go to sleep, and then once they go to sleep, they're very relaxed, and that relaxation of the tissue causes it to really flutter in the breeze of the air moving in and out. Crowing often, and stridor both, are often heard when airways get narrowed. Typically its upper airway structures are narrowed a lot of times from some sort of an infection, and that causes them to either have this the crowing or the high-pitched squeal of stridor. Sometimes that also occurs from artificial blockages, or what we call foreign body airway obstructions. Now, auscultating and lung sounds. Lung sounds on both sides during inspiration and expiration. The best way to assess your lung sounds, and if you look at 452 in your textbook, you see the places that we should most often listen for lung sounds. If you have easy access to the back, it's good to listen to the back. If you can only get to the front, it's acceptable to listen in 4 or 6 spots, but you should usually go directly above the nipple, or where the nipple should normally reside, just an inch or so down from the collarbone on each side, and then you can work your way down towards around the nipple area, or where the nipple typically would reside. And then finally, your last spot would be to move yourself over into the armpit area, really, or almost slide off to the side from where the nipple should reside, and listen in the armpit area. If you're listening on the back, keep your stethoscope off of their shoulder blade. So go between the shoulder blade and the spine, and then go underneath the lower edge of the shoulder blade. The shoulder blade will muffle your lung sounds, so you won't hear them nearly as well. So staying away from those. But that would be the typical spots to listen. And you usually should kind of do this in a Z pattern. So if you listen upper left, then you move to upper right, and then you move to lower left, and you move to lower right. And one person needs to check the lung sounds because it's another objective thing. If somebody can be checking the lung sounds one time, or maybe you only listen on one side, your definition of what the lungs sound like may not match up exactly with your partner who listened to the other side. Additionally, if you listen to lung sounds and then you gave them some sort of a treatment, and you listen to lung sounds again, you're going to know whether or not they sound better, worse, or about the same. So a couple of lung sounds to listen for. Wheezes. These are a high-pitched, really kind of a musical sound, and this is air moving through narrowed airway passages. This is very commonly seen in asthma patients and patients with COPD, but those are not the only patients that have those. We commonly associate it to asthma, but that's not the only disease that creates wheezes. So it's a very high-pitched, almost musical sound. Sometimes it's when they inhale, sometimes it's when they exhale, and sometimes it's both when you'll hear the wheeze. Crackles. Crackles is also sometimes called rales or rales, R-A-L-E-S, R-A-L-E-S. This is a fine crackling sound caused by fluid in the alveoli or by opening of closed alveoli. And you can kind of simulate the sound of that by, if you have hair long enough that you can kind of get a couple strands of hair between your fingers and rub it right in front of your ear. That kind of crackle, crackle, crackle sound that you hear, that is what rales or crackles typically sounds like. We have rhonchi. Rhonchi is a lower sound resembling kind of a snoring or a rattling. This is caused by secretions in the larger airways. Rales or crackles are secretions in the lower airways or the smaller airways. So rhonchi is usually, think of rhonchi as being thicker mucus, and rales or crackles is typically just thin water. That's kind of the way to try to think about those things. But rhonchi is very coarse, very and like it says there, kind of a snoring sound in there. Stridor. Stridor is a high-pitched upper airway sound. It indicates a partial airway obstruction of the trachea or the larynx. And remember, this can be either foreign body, so a piece of food, a toy, whatever, maybe even a tooth or part of the person's tongue has gotten lodged in there, or it can be from swelling. And the most common time we hear stridor is actually in kids with some sort of infection, croup or epiglottitis, in which they get this high squealing sound because their tissues are all swollen up from the infection, and it's harder for air to move in and out, so they squeak a bit. So, vital signs. So some changes we may see. An increase or a decrease in pulse rate. Typically, it starts out with an increase and later on in the process becomes decreased. Obviously, changes in the breathing rate can be higher, can be lower. Somebody who's early in the process of some sort of a respiratory problem typically will have higher respiratory rates, and then as they get exhausted and worn out, their respiratory rates drop. Changes in the rhythm of their breathing. Oddly, there's not a lot of changes in breathing rhythm for a lot of breathing problems. A lot of times when we see changes in breathing rhythm, it's more neurologic or something that has to do with the nervous system. But there are occasionally you'll see people they're struggling so much that try to just grab a breath whenever they possibly can. They may have hypertension or hypotension, so their blood pressure may shoot way up or it may drop way down. That's going to depend a lot on what medical condition they're dealing with. And then their oxygen saturation. Okay, so here we have a pulse ox on this patient. And I know we've talked about the pulse ox before, but we'll just real briefly touch on it again. A pulse oximeter uses a couple of different waves of light, shoots it through the tissues, and whether that's either a fingertip, a nose, an eyebrow, a earlobe, a toe, those are the areas that typically we'll attach the probe to. And when it bounces those light waves through there, it measures how much of the light comes back and from one different type of measure to the other, and it will tell you approximately what percentage of the hemoglobin, which is the compound, we'll call it the sticky glue on the red blood cells that attaches oxygen, but it tells you what percentage of red blood cells have full saturation or have all of their sites filled up with a gas, and in most cases that gas is oxygen. However, carbon monoxide attaches 200 times faster than does oxygen to the hemoglobin, and the pulse oximeter can't tell the difference. So let's say we have people start to flip their furnaces on soon. We'll see a rash of carbon monoxide poisonings coming about. And we might see all kinds of people who are complaining of headaches, dizziness, altered mental status, cherry red lips and skin, and the whole house is feeling the same way after turning their furnace on yesterday or today, and but their pulse oximeters are all reading 99, 100%. Well, it's true that 99, 100% of the hemoglobin is saturated. It's just not saturated with oxygen. The other thing that the pulse ox tells us is the heart rate, an approximate heart rate. That heart rate should match the pulse that you have taken on your patient, or be very stinking close. So if you have you're taking a pulse on a patient and it says 112, and you put the pulse ox on them right now, and you see that the pulse ox says 80, you have a mismatch. That doesn't match up. It says the heart rate here is 80, but when you were feeling the pulse in their arm, it's at 112. That's way off. Something's not right. The other thing you can see here on this example, and most pulse oximeters have something similar, is there's that little round light underneath the 80 there. And that little light usually blinks in one of three colors, and it's the stoplight colors. It's red, yellow, or green. Green is a good signal. Yellow is a not so good signal. Red is a bad signal. You want to have a green flashy light. Every time the heart beats, you want to see it pulse green, pulse green, pulse green. And that helps you determine that, yes, this is a good reading. And in most cases, if you're getting a green flash there, then your heart rate number matches up with your pulse rate number that you took from taking the patient's pulse. So to move on to some of the patient care items, we first of all need to assure adequate ventilation. The rest of it doesn't matter much if the ventilation isn't going on. So if we don't have good ventilation, we can do all the other kind of fun stuff, whether it's controlling bleeding or splinting broken bones or using a nasal cannula or a CPAP device eventually. None of that matters if the patient can't move the air in and out on their own. If they cannot do this, then you have to ventilate them. So if you can get away with not ventilating them because their respiratory efforts are sufficient, then you need to consider putting them on some sort of supplemental oxygen. In most cases, if the patient's complaining of difficulty breathing, we want to consider a non-rebreather at 15 liters per minute. We treat the patient, not our monitoring tools, not our pulse ox. If we have a patient who's really struggling to breathe and their pulse ox says 100%, we have to believe the patient, not the monitor. The monitors can be tricked easily. So if they're really struggling, then they're going to probably get the non-rebreather at 15 liters per minute. If really shortness of breath isn't their major concern, or they're just very mildly short of breath, and their pulse ox is maybe 92, 93, 94%, we might put them on oxygen via nasal cannula at 2 to 4 liters or even up to 6 liters if necessary, and see if that helps them out. If it doesn't, if they still keep a low saturation, they continue to really struggle to breathe without much improvement, then we can switch them up to the non-rebreather. We're going to place them in a position of comfort. Position of comfort is huge. People think we put them on an ambulance stretcher, well, they're going to be laying down. Laying down doesn't work for a lot of people with shortness of breath. A lot of times it needs to be head up, almost as far up as it'll go. I've had to transport patients with their feet hanging off the sides of the cot just because that was their position of comfort. It's the only way we could get them comfortable enough to transport. If they have a prescribed inhaler and we have the appropriate protocols to do so, then we can consider assisting them with their inhaler. We're going to have to discuss that a little bit further, but system with their prescribed inhalers. And then consider continuous positive airway pressure, or CPAP. And CPAP, once that comes into the scope of the EMT, I think it'll get be greatly received, and it definitely will be added bonus to your scope. So it's really a fairly simple procedure. This blows oxygen or air continuously at a low pressure into the airway. This is the same device that many people, including myself, sleep with at night because we have obstructive sleep apnea, where we don't breathe quite as normally as a lot of people do. People who have constant snoring may startle awake several times at night. Their partners tell them, hey, you stop breathing in the middle of the night, potentially have obstructive sleep apnea. The number one problem that causes this, probably myself included, is just being overweight and inactive, and it causes excess fat tissue to deposit there, and it helps create more obstruction. It prevents alveoli from collapsing at the end of exhalation, because the alveoli are kind of like balloons, and the balloons can slam shut if there's nothing in there. And this can also prevent fluid from shifting into the alveoli from the surrounding capillaries. People with congestive heart failure have this problem where they're usually their high blood pressure, and they have a little bit too much fluid in their system, and that fluid leaks because it can't stay in the vascular space, and so it leaks across the capillary and it fills the alveoli. Well, this obviously causes problems because it makes it much more difficult for air to move through there. So a lot of times patients will end up on CPAP who are having a flare-up of their congestive heart failure, and this CPAP will help keep that fluid, that water or edema, from rushing into the into the alveoli. It keeps it in the vascular space. If you would like to try CPAP, there's a very simple way that you can attempt to feel how CPAP works on a patient. Next time you are a passenger in a vehicle running down the interstate or the highway at 55, 65, 75 miles an hour, roll down your window, stick your head out the window, and just try breathing. Any of you guys that have been in the fire service and have used a SCBA, the SCBA kind of has a similar feel to it as well. It's just a constant air blowing in your face, and it requires a seal. Without the seal, then the CPAP won't work. So it's not like you can just kind of put it up against your face when you take a breath in and then take it down. You have to have that constant seal, and with that constant seal helps maintain a different airway balance. So the amount of pressure is measured in centimeters of water pressure. There are a lot of people who are on what's referred to as physiologic ranges of PEEP, which is 2 to 5 centimeters of water pressure, which is very similar to what we have here in atmospheric air. But when we start to pump that up to 7.5, 10, 12.5, 15, up to even 20 centimeters of water pressure, it's that much more pressure blowing in their face. So it's commonly used in pulmonary edema, drowning patients. Pulmonary edema comes along with congestive heart failure, asthma and COPD, and then just general respiratory failure. There are some problems with CPAP, though. It is contraindicated in the patient with a severely altered mental status. They're a little anxious, they're a little upset. That's okay. This is probably going to make them a little more anxious. But if they have some slight changes in their anxiety or mood, that's not a problem. They're unconscious and can't hardly hold their own airway open. This is not for them. They need to be ventilated. They lack the normal or spontaneous respiratory rate. If the person can't breathe on their own, then the CPAP will not work for them. This is an adjunct to assist with their current breathing. If they're not breathing, you have to breathe for them. CPAP will not push air into them sufficiently. If they are in hypotensive or in shock, because CPAP changes the dynamics of the pressure within the chest, it changes the way blood flows, and it will make shock or hypotension worse. So it cannot be used on hypotensive patients. Patients with nausea and vomiting, we need to watch them closely. It's not absolute, but we need to watch them closely and tell them, if you feel that you're going to throw up, you let me know and let's get this mask off. Because if they throw up in the mask, this is going to blow it right back in their face. Penetrating chest trauma, or something called a pneumothorax. If they have a pneumothorax or a sucking chest wound, this messes up the dynamics and it's going to actually create a bigger problem. It's going to make their problem with difficulty breathing much worse. Upper GI bleeding, so they're vomiting blood or coughing up a lot of blood, and that blood's actually coming from their gut. This can increase the amount of pressure within their abdomen. Most people who wear a CPAP at night, the first thing they do when they wake up in the morning and they take their CPAP off is belch. And that's because some air has gotten forced into their stomach. And then conditions preventing a good mask seal. So if you're trying to deal with one of the Duck Dynasty guys with their giant beards, you could have a very difficult time getting a good seal with the CPAP. It's the same reason why firefighters are not allowed to have beards, is because they have to be able to seal an SCBA mask. Side effects, again, hypotension can be one. It can create a pneumothorax, which is a collapsed lung. It increases the risk of aspiration, so that was that discussion regarding nausea and vomiting. Aspiration is when you suck something into the lung that's not supposed to be there, like vomit. And then drying of the corneas. Because there's so much air moving around there, it can dry out your eyes a little bit. The mask doesn't usually cover your eyes, but there's usually a slight amount of a leak right up there around your eyes and nose, and it can dry out your eyes a bit. That's relatively minor, particularly in the grand scope of things. If we put this person on the CPAP, they're going to be on it in our care for 15-20 minutes maybe, and then they can. There's other things they can do with that in the hospital. So if you were going to use CPAP, and this is not an authorization for you to do this, it's just a quick once-over, you need to explain the procedure to the patient. Start with a low level of CPAP. That's going to depend on the device you're using. We are not going to dwell on that because it's not in your scope yet. Reassess their vital signs, their dyspnea level, and then increase CPAP as you go within a few minutes. They're showing this type of CPAP device is a disposable device. It actually works very well, but in the claustrophobic patient it can kind of be a problem. This has got this big head strap on it to help keep it sealed up against the face, and the way that you change the CPAP level on these is by increasing your amount of oxygen that you are using. So if you might go from 10 liters per minute to 15 to 20 to 25. If the patient deteriorates, remove the CPAP mask and ventilate the patient. So the patient apparently has gone unconscious here. You need to get your bag valve mask out and get ready to bag this person immediately. All right, so the various respiratory conditions. So if we were to take a moment and try to write down all the causes of respiratory problems or conditions, complaints of shortness of breath, we would spend more than a few minutes and probably fill a whiteboard or a sheet of paper easily with the number of things that we came up with. There's only a few things that we're going to touch on here in this chapter. There are many, many more. And there are lots of things that can cause difficulty in breathing, but they're not usually major causes or significant requests for EMS. So we don't go into lots of detail with those. So number one we'll discuss is chronic obstructive pulmonary disease, or COPD. You probably have heard of this. You see all kinds of commercials on the TV for it. This is a broad classification, or a family of chronic lung diseases. Chronic meaning long-term, obstructive meaning blocking, and obviously pulmonary meaning respiratory. So something is blocking. Now, the three diseases that typically fall into this category are emphysema, chronic bronchitis, and black lung disease. Black lung disease is a fairly small player in this. There's not a lot of people with black lung disease that particularly that we deal with in the Midwest, but it does fit in this category. The overwhelming majority of cases are caused by cigarette smoking. It's just plain and simple. My mother has COPD, was diagnosed with COPD a number of years ago, and had been a lifelong smoker. And it really truly is a major significant health problem. And once you get COPD, you get it forever. It doesn't go away. Sometimes it gets a little better for the short term, but it will rear its head. So chronic bronchitis, this is the inflammation of the bronchial lining. So if you remember, the bronchioles are the tubes that lead from the trachea to the alveoli. There's an excess of mucus produced, and the cells in the bronchioles that normally clear away the mucus are unable to do so. Interesting thought here, concept that goes along with this. People who are smokers are doing themselves no favors by continuing to smoke after they've gotten COPD. Smoke paralyzes the cilia. The cilia are the fine little hairs that sweep away the dirt and the mucus from the lungs themselves. So once you stop smoking, within about 72 hours, the cilia start to wake up and start to do a cleaning job. That's why a lot of people who try to quit smoking after several days to a week or two, they're like, I breathe better when I'm smoking because I'm constantly hacking up all this crap. Well, that's because you've smoked for so long, and with those paralyzed cilia, all that stuff just sat there and accumulated. Now it's going to take it a while to sweep out the shop again, so it can be try to clean things up. So with the chronic bronchitis, though, with this inflammation, they're not doing their job as well as they possibly could be from some sort of usually an infection or some sort of a minor trauma to them. And so the big problem with the chronic bronchitis is they just have all this mucus stuck in their bronchioles. People who have chronic bronchitis alone are often referred to as blue bloaters. Blue bloaters refers to they're typically edematous or swollen, typically a little heavier patients, and they're frequently cyanotic. So here it shows an example of a chronic bronchitis where they're showing some inflamed bronchioles there, some constriction a bit, as well as the mucus starting to plug those passageways. So it's just like when you have mucus accumulating in your nose and you're struggling a little bit because you have a cold or allergies or whatever, it's a little harder for you to breathe up top. That's the same sort of thing that's happening down below. Emphysema. Emphysema, this is the alveoli walls have broken down. Their surface area for respiratory exchange is greatly reduced, and they just don't function at capacity. Typically, alveoli in the healthy person has a little bit of an elastic snap to it, so when you exhale, they kind of snap back to their normal size. People with emphysema, they lose that elasticity. So I like to think about it as if you take a balloon, pull it out of the package, and you know what size it is. Then you blow it up. You leave it lay around, blown up for a week or two. Then you go and pull the knot out, and you let all the air out. That balloon does not go back to its normal size that it was when you pulled it out of the package. It's forever lost part of that elasticity, and it won't get back to where it was. So with emphysema, it's the same sort of thing you have going on with the alveoli. And without that elasticity, without that snap, air gets trapped. So actually for both COPD patients, or both major COPD patients, it's not usually an asthma included, I guess, although it's not a COPD. The biggest problem for most of these people is they can't exhale fully. It's not that they can't get a good breath in, it's they can't get the last breath out so they can exchange it for a new good breath. People with emphysema are often called pink puffers. These are people who a lot of times will have pursed lip breathing. They will be very pink in color and often fairly thin when they have emphysema. Now, people can have both chronic bronchitis and emphysema, and it kind of throws their characteristics for a loop a little bit. But people that are very pink in color with emphysema because they've had to make extra red blood cells to keep their body oxygenated because their body was tricked for so long, and the body doesn't do an efficient job of moving oxygen back and forth through the alveoli. It had to build up extras in order to accommodate. So in the example of emphysema here, we may also have some thick mucosa or the walls of the bronchioles or the terminal bronchioles. You may get some bronchospasm, in which actually the muscles start to constrict down. The bronchioles can start to collapse, and then with that lack of that snap, you get air trapping. Now, asthma doesn't fit specifically in the COPD categories, but it fits in what's often referred to as the OPD category, which is just plain obstructive pulmonary disease. It is a chronic disease, but it doesn't have the same typical characteristics as the emphysemas, chronic bronchitis. Usually people will have just episodic exacerbations, meaning occasionally they'll have something happen which causes them to have a flare-up. During the attack, these small bronchioles narrow from bronchoconstriction. Their biggest problem is the muscles are constricting down, and then they will start to produce mucus. So it kind of mimics both emphysema and chronic bronchitis in certain ways. And it results in these small airway passages basically being closed down with severely restricted airflow. And again, they have a lot of air trapping during asthma. So airflow is mainly restricted in one direction. On inhalation, it expands the lungs and exerts an outward pull, increasing the diameter of the airway and allows air to flow into the lungs. And upon exhalation, the opposite occurs and air becomes trapped. So they try to get the air out, but they just can't. So it's stuck. They can't get another good breath in because all the bad old breaths are stuck. So here's kind of a picture of how asthma might look. You've got your bronchiole, bronchus breaking down into your bronchioles and so on and so forth. The smooth muscle bands kind of constricting and breaking and bringing the size of those bronchioles down. You get mucus in there that starts to block some of those, and then the alveoli are almost hyperinflated from air trapping. Pulmonary edema. Pulmonary edema is an accumulation of fluid in the alveoli. This can happen a little bit from some of the COPDs. The most common causes of pulmonary edema, though, are congestive heart failure, which is actually a circulatory problem. The circulatory system can't keep up, and there's excess fluid, and with that excess fluid, there's nowhere to go. But hey, look, there's an open space on the other side of the alveoli wall. Let's go put some water there. The other big thing that causes this is people with toxic inhalation. So they're exposed to some sort of a toxic gas. A good example might be anhydrous ammonia in the agricultural setting. And that helps to pull water into the alveoli. These people will experience significant difficulty breathing because you put water in the space where air is supposed to be. So like I said, when it's caused by congestive heart failure. There's excess pressure in the pulmonary capillary. Remember that it's only two thin cell walls, or two thin cells between a capillary and the inside of an alveoli. You got to get to the capillary wall and the alveolar wall, and that's it. Fluid will cross that thin barrier and it will accumulate in and around the alveoli. So you might have some fluid sitting inside the alveoli, or you might have some fluid trapped between the capillary and the alveoli. Kind of makes it a wider little space for that oxygen CO2 to try to get across. When the fluid occupying the lower airway makes it difficult for oxygen to reach the blood because there's extra barriers, extra layers. And in these cases, these patients will experience dyspnea. They can't get a good breath in because there's water or plasma taking the place of where air should be. Common signs or symptoms of this: dyspnea, obviously complaining of shortness of breath, very anxious, pale and sweaty skin, even sometimes cyanosis. Tachycardia and hypertension often go with this, as do low oxygen saturations. Patients will usually have some crackles. Sometimes we'll have wheezes, and those wheezes may be audible. Patients can cough up frothy sputum, usually white, but sometimes pink tinge. So it almost looks foamy. Foamy pink or white foam is very common with the pulmonary edema patient. Treatment is assess and treat for inadequate breathing, high concentrations of oxygen, and if possible, keep the patient's leg in a dependent position, so put them down if possible, and CPAP. So to think about it, might it be possible for patients to have multiple respiratory disorders? Absolutely. Happens all the time. We have a lot of patients who have COPD and CHF both. Could a person with an underlying diagnosis of COPD also have pulmonary edema? Absolutely. All right, so a little bit different cases here. These are less of a chronic issue and more of a acute issue that they're potentially going to be dealing with. Pneumonia. Pneumonia is the infection in one or both lungs or parts of lungs, and it's typically caused by either bacteria, viruses, or fungi. Bacteria are the most common ones, but you certainly can get viral or fungal infections there. Results from the inhalation of certain microbes. So when we got people who are sneezing and coughing and not covering their mouth, that gets exposed to the air, can be pulled into the lung, and if the person's not well, they can't fight it off. And so that microbe starts to grow in that lung and it causes the inflammation. The typical signs or symptoms to go with pneumonia are shortness of breath with or without exertion. So when we say with or without exertion, a lot of our complaints that we had earlier, the CHFs, the COPDs, the asthmas, usually are worse with exertion, but pneumonia can be either or. Coughing, and typically it's going to be if they have a productive cough, it'll be a yellow or green color. They may have a fever and chills. Fever is one of the kind of red flags that you see when you're talking about an infection. CHF, COPD, those people, if they have specifically just their COPD, CHF, or asthma, they probably don't have a fever. They may have chest pain. It's often sharp or pleuritic. So when we're talking about patients with chest pain, we may ask them, describe your pain to me. Can you point to where your pain is? And they can almost put their finger exactly on where it's at. It's not very vague. It's not, oh, well, it's all across my chest. It's right here is what they'll tell us. Headaches, pale, sweaty skin, fatigue, confusion. Treatment for these patients is mostly supportive care. It's going to be positioning. It's going to be oxygenation, ventilation when necessary, and transport. Even at the paramedic level, there's not much that we can do for patients with pneumonia. Although patients with pneumonia typically do get dehydrated, so a paramedic might start an IV and give them a little bit of fluid. The medications that we carry in the ambulance are usually not terribly effective for these people, and what they really need is some sort of an antimicrobial, an antibiotic of some sort, to help fight whatever it is causing their problem. The spontaneous pneumothorax, this is a fairly uncommon thing to see, but this is a lung collapse without any other injury or obvious cause. Most of the time when we deal with a pneumothorax, which is collapsed lung, it's as a result of trauma. Somebody got shot, stabbed, had blunt trauma, rocked forward and hit the steering wheel when their car crashed, something along those lines. But you can also have it just spontaneously. The most common people that we see this in are tall, thin people that are smokers, and often they are male as well. So the tall, thin male smoker and young, this happens to high school kids. When we talk about getting called to a basketball game for all of a sudden a person had sudden onset shortness of breath, we show up in one of their lungs. We don't hear any lung sounds when we listen to their lungs. That's, in many cases, spontaneous pneumothorax. Signs and symptoms of this are also going to include that sharp pleuritic chest pain. So sharp chest pain is that, fingertip, you can point right to it. Pleuritic is more as they breathe, it feels like it's almost scraping or almost like two pieces of sandpaper rubbing together. They'll have a decreased or an absent lung sound on the side with the injured lung. And this may be up high, this may be down low. In most cases, you'll start to hear more decrease of lung sounds up high as that air tries to rise away from gravity. Shortness of breath and dyspnea on exertion that continues to get worse and worse and worse and worse as the process goes. Low oxygen saturations and cyanosis. Tachycardia, very common. Treatment for these people is actually pretty rapid transport. We're going to give them some oxygen. We'll ventilate as necessary. Be careful if you have to ventilate, not to ventilate too fast. Ventilating too fast will make the problem worse. No, 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 no CPAP for these people. And if you have the opportunity to call for ALS, particularly paramedics. Paramedics sometimes will stick a needle in a person's chest to let out the excess air. A pulmonary embolism. Pulmonary embolism, again, is a cardiovascular problem. It is not a pulmonary problem. However, it shows up as a pulmonary issue. A pulmonary embolism is a blockage in the blood supply to the lungs. So the heart's trying to circulate blood through the lungs to be reoxygenated, and part of that blood flow is stopped. So usually this is caused by a blood clot, and in some cases it's caused by a DVT or a deep vein thrombosis that migrated. So a DVT is a blood clot that is formed either in the arms or the legs, and sometimes they will break loose and travel and then become lodged somewhere in the lungs. In these cases, a whole section of circulation to a part of the lung is blocked. However, the lung will not start out having a normal breath sound there because it's actually not a problem with airflow. It's a problem with the circulation around the alveoli. Eventually, they will start to get some crackles or some rails in that area. The increased risk for pulmonary embolism or any really blood clot, whether it's a stroke, a heart attack, a pulmonary embolism, a DVT, comes from limited mobility. So somebody's had a recent fracture in a cast. Maybe they traveled across country. They've had a recent trauma in which the body tried to build up clotting factors to deal with. And then the abnormally fast blood clotting. So people who have certain types of blood disorders in which they build too many platelets. These people. Recent surgeries. Women on birth control, or really certain types of hormones. Doesn't have to be women, it can be men as well. Smokers are also at a higher risk for pulmonary embolism. So their signs or symptoms include chest pain, shortness of breath, low oxygen saturations and cyanosis, tachycardia, and later will become wheezing. You don't often hear wheezing right off the bat. So just because they don't have wheezing doesn't mean they don't have a PE. Treatment. This is very difficult to differentiate in the field. We often have to run several different types of tests to determine is this actually a PE versus another cause of chest discomfort. We're going to make sure that they're well oxygenated and well ventilated, and then we'll transport to definitive care. Certainly you can call for ALS in these cases. There's not a lot, though, that the paramedics are going to be able to do as well. Epiglottitis. This is an infection causing swelling around the glottic opening, or actually to the epiglottis. In severe cases, the swelling can cause a airway obstruction. The signs or symptoms, and this used to be considered really a childhood illness, and that's the primary population that we see it in, but it's becoming more and more popular in, or more and more common, I should say, in the younger adult populations who didn't get all their vaccinations like they were supposed to. Pediatric patients that are vaccinated and regularly on their vaccination schedule typically are fairly safe from this. Not absolute, but safer from this than if they got none. The typical signs or symptoms are a sore throat, drooling, difficulty swallowing. Anytime that fluid flows back and touches the epiglottis, it becomes very irritated. They prefer to be bolt upright or in a tripod position. Usually they'll have their head hanging over so the drool just falls out of their mouth. They typically look very sick. They'll have a muffled voice because airflow is restricted. They will usually have a fever and stridor. Most commonly seen in the children ages 2 through 7. The biggest culprit for epiglottitis is actually the flu virus. And fevers tend to be a little lower in kids with epiglottitis than kids with something called croup. Croup is another childhood illness croup usually is a little slower onset. Epiglottitis, they can go to bed just fine and wake up in the middle of the night in a world of hurt. So with epiglottitis, our main goal is keep them calm and comfortable. Keep your fingers and tools out of their throats because you can actually cause a spasm of their tissues. Administer high flow O2 if possible, and then transport. Do not put anything in their airway if you don't have to. Cystic fibrosis. This is a genetic disease. It typically appears in children. Adults can have it. The thing about most cystic fibrosis, though, is they don't have terribly long lifespans. It causes thick, sticky mucus accumulating really in all parts of the body, but mainly the lungs and the digestive system. We think of cystic fibrosis as strictly being a respiratory problem, but it actually is multiple issues. This mucus can cause a life-threatening lung infection, as well as problems with digestion. They typically will have coughing with large amounts of mucus, be very fatigued, very, very tired, have very frequent bouts of pneumonia, complain of abdominal pain and distension. They may be coughing up blood, have some nausea and vomiting as well, and weight loss. Treatment for this is really completely supportive. We give them O2 and ventilate as necessary. Caregivers are going to know much more about this cystic fibrosis than you do. So if there's some things that they can share with you that can help make their loved one more comfortable, try to accommodate those. A few viral respiratory infections that we deal with from time to time. RSV typically is the one that we hear the most about in kids.
which is respiratory syncytial virus.
These are usually minor, but there are certainly a few that will pop up from time to time that create some pretty horrific problems for kids. This is really very common in kids. Often they'll start with a sore, scratchy throat, maybe the sneezy, runny nose and fatigue, which sounds like really just any normal childhood illness, fevers and chills. Infection can be spread into the lungs, causing shortness of breath. And they may have a constant supply of green or yellow sputum, which is a pretty good indicator that it is some sort of an infection. When you're dealing with any suspected respiratory infection, remember to protect yourself and protect your patient. So masks to prevent the cross-contamination. Oxygen as necessary. Now the nice thing about if we put a kid on or put somebody with a respiratory infection on a non-rebreather, we do trap a lot of their infections. It's not perfect. We should still be wearing masks ourselves, but with a mask it helps kind of restrict those a little bit. And then good hand washing is of course key, and then keeping your equipment cleaned up. So there's a video on chronic obstructive pulmonary disease, as well as a spontaneous pneumothorax. You can look at those in the other version of the PowerPoint. So to talk just very briefly about a prescribed inhaler, you are allowed to assist patients with their prescribed inhalers. It's called patient-assisted meds. Here's an example of a lady using a rescue inhaler or a prescribed inhaler. What these do is a meter dose inhaler provides a very precisely measured dose of the medication. Most of the time those inhalers have around 200 doses in them, and it's most commonly just prescribed for conditions causing bronchoconstriction. Asthma and COPD are the ones that most commonly get this. Now, before administering the inhaler, you got to check your patient rights. Is it the right patient, right med, right route, right dose, right time to do this? Check the expiration. Is there some sort of a prescription that helps us identify if this actually belongs to this patient? You need to shake the inhaler up. Is the patient alert enough to use the inhaler? And if they have a spacer, try to use that. The inhalers you're going to be using with these patients are certain types. Not every inhaler is appropriate. So your protocol will probably tell you which inhalers the patient can use, or you can assist the patient with, or you can contact medical control and tell them what the name of the medication is. Most of these medications will be albuterol sulfate, sometimes also called Venolin, ProAir. Those would be some more common names that you would hear for it. But not all inhalers are made the same. There are a lot of inhalers that are daily maintenance things that won't help you if you're having an emergency right now. An example of a aero chamber spacer device. The way this thing works is it just has some little flapper valves in there, so when you push down on the top of the inhaler, you push down on the silver part, it actuates and shoots a dose of medication. It shoots it into the aero chamber, and then the patient can then suck it out. If it takes 2 or 3 little hits off of there to get it all out of there, they can do that. It keeps it from just getting lost into the atmosphere. So if the inhaler is prescribed to them, you have the appropriate protocols or medical control to do so. Have that patient exhale deeply, put their lips around the opening. Once their lips are around the opening, then press the inhaler to activate the sprays as the patient inhales deeply. Ask them to take as deep a breath as possible and try to hold it for as long as possible. Because if they just do a quick in out, then they really had no opportunity to expose the lung tissue to that medication. So if they're able to hold it in there for a second or two at least, that at least gets some contact with the lung tissue. That shows you a video on using the inhaler and the spacer. small volume nebulizer. We are not going to dwell on this, but basically this is really the same concept, only instead of using a pressurized canister, we use pressurized gas. So we use our oxygen bottle, and we will put some medication into a little canister that will then, and you can see this on page 465, but we'll drop some medicine into a canister. The oxygen bubbles it. It looks like it's kind of smoking. A lot of times you see they're smoking the peace pipe. And it gives the patient a greater exposure to medication. This usually takes around 8 to 10 minutes for it to finish up, and that would be one additional method that advanced EMTs or paramedics or EMTs in Nebraska can actually take an additional class to be able to do those. So for our chapter review, remember it's important to understand your anatomy that you're dealing with, the physiology, the pathophysiology for the patients with the various respiratory emergencies. Patients with respiratory complaints can exhibit inadequate breathing. Sometimes they wait too long to call us, and instead of it actually being shortness of breath, it's no breath. Very slow and shallow respirations are serious. That means they are fixing to die. Usually, if they're complaining of shortness of breath, their respiratory rate is very high. When it becomes slow, they're worn out, they're done, they can't keep doing this. History can give us tons of good information, and you allow, as you grow and develop in your history or your career as an EMT, you will learn to ask certain questions. You'll pick up on certain patterns and use those to your advantage when you're assessing your patient. There's certain physical exam points that we're really concerned with, and we're looking at things like work of breathing, accessory muscles, nasal flaring, pursed lip breathing. Do we see any edema either in the sacrum area or the ankles? Jugular venous distension occasionally, where the veins on the side of the neck bulge out. We talked about that before. And then there are often medications that can help the patient with difficulty in breathing. Depending on what your system and your protocols are, you may be able to assist with that. You need to make sure that one of the very first questions you ask is this breathing adequate, inadequate, or absent? And then you either oxygenate or ventilate. Consider whether to assist the patient with their own medications. We're going to kind of skip over that. So some additional questions to consider. What would you expect a patient's respiratory rate to do when a patient gets hypoxic, and why? Initially, it goes up as they try to compensate for that, and then it will go down as their body has now worked in an oxygen depleted environment for some time, and the body just has started to wear out. What would you expect a patient's pulse rate to do when they get hypoxic? Again, it goes up initially and then down as they try to compensate, and then as they wear out. List of signs of inadequate breathing, you can do that. Would you expect to assist a patient with their prescribed inhaler when they are experiencing congestive heart failure? Why or why not? In most cases, patients with CHF are not on a lot of bronchodilators. They may have one or two, but most of the patients with bronchoconstriction are the ones that have inhalers. Where congestive heart failure patients don't have bronchoconstriction, they have fluid in their alveoli. List some differences between the adult, infant, and child respiratory systems. You've got a whole slide on those. Your critical thinking, you have a 72-year-old female complains of severe shortness of breath. Her husband notes that she is confused. You note her respiratory rate is 8 per minute. She is cyanotic. The patient has a history of COPD and CHF. So what are some of the treatment steps that you would do for this patient? If she is confused, respiratory rate of 8, and she is cyanotic, she has inadequate respirations. And her inadequate ventilation and respiration requires us to step in and ventilate for her. So we would need to begin to ventilate her either with a mouth-to-mask or a bag valve mask device. usually with high flow oxygen, and that would be our first steps in trying to correct her underlying respiratory issue.